So, welcome to Live from One Cancer Place, the inviting front door that welcomes all cancer patients. Here we help you learn the language of cancer while we provide you with a map of cancer land. We welcome you, we introduce you to people who are living with and surviving their cancer, and we want you to join us in experiencing cancer as a chronic condition. I am Erica Hansen-Brown, founder and CEO of One Cancer Place. I myself survived a bad case of colon cancer 20 years ago. I now devote my life to helping other cancer patients find their way to that cancer land map. Now I'd like to introduce you to a couple of friends of mine. Dr. Chris Heery, Chief Medical Officer of Arcellx, a cancer biotech focusing on CAR T therapies. Dr. Chris is our Starr Chief Conversationalist for our live productions, but you will also notice that he's darn good at teaching concepts that come up with these doc-to-doc discussions. Dr. Jason Starr, hematologist oncologist at the Mayo Clinic, Jacksonville, Florida, has several oncology specialties, but one of his favorites is the very difficult neuroendocrine malignancies in the gastrointestinal tract, and he has also co-authored several papers and book chapters on that subject. Dr. Starr is committed to advancing the field through clinical research, namely through the development and enrollment of clinical trials. Practicing clinician, he is board certified in internal medicine, hematology, and oncology. Dr. Starr and Heery, let's talk.
Thanks, Erica. Yeah, I think a great place to start would be, Jason, would you mind kind of telling us how you decided to become an oncologist, how you got interested in oncology in the first place?
Yeah, I love that question. We usually don't start with that, so I like that. So first, thanks for having me. I love to have the opportunity to teach others, particularly patients and then patient advocates. I always tell my patients that they will be experts in neuroendocrine cancer. They will be the expert of their disease, and they'll teach other physicians about it. But my decision to become an oncologist it wasn't one of those situations where I had a family member, surprisingly, because so many of us have family members or have some personal experience with cancer. Through medical school, I was originally interested in surgery, and what I loved is connecting with people. And when I did internal medicine, I realized I had that opportunity. I had the ability to problem solve. And then I did my first oncology rotation when I was a third-year medical student with Dr. Scott Tetro. He's now in Tallahassee practicing with Florida cancer specialists. And I was hooked. It gave me everything that I wanted out of a career in terms of the connection with the patients, the ability to be there in a very sacred space when they're going through the most difficult, situation and that they've been faced with in their lives, and then to be able to navigate that with them. We talk about navigation and patient navigation, and that's kind of what this is about. And then there was just some magnetism, right? I think in oncology, it attracts a certain type of person. And you develop kind of a magnetism towards wanting to do it. And that's what I say. It kind of chose me. I'm not sure that I chose it as much as it chose me.
Oh, that's awesome way to think about it. I think that first, some have probably heard me say this before, but internal medicine is such it is just one of those things that it's a specialty that really draws in people that are attracted to the way you are inspired to think. And it's kind of the only part of medicine I found, at least, that allows you to think about the entire system of the body and how the interactions have to work. And not everyone is going to enjoy working that way, right? So it's funny that you say that. And then I think the part of being part of the most important decisions in a patient's life is something that I think is probably pretty consistent across almost all oncologists. It's again, it takes kind of a different way of thinking from other specialties to want to be a part of that. So I think we can say we're all glad that people like you exist and started down this path. But then from there, you went to a subspecialty, if you will, in a very particular type of tumor. And if you don't mind, could you just kind of give a broad overview of the definition of what neuroendocrine tumors are and how they're unique from other cancers, maybe?
Absolutely. So it's interesting. Every neuroendocrine paper starts with neuroendocrine cancers are a heterogeneous group of malignancies that can arise anywhere in the body. It's kind of funny. It's like a little bit of a joke when writing manuscripts, but that's essentially what it is. So neuroendocrine cancers can arise anywhere in the body. They arise from specialized cells, right? So cells in the body that have certain functions, that have a certain responsibility. For example, in the pancreas, these neuroendocrine so-called cells make insulin or make other hormones, right? In the bowel, these neuroendocrine cells make serotonin to help with gastrointestinal motility, to help the bowels move. So these cells have specific functions, and essentially something goes awry in the cell, a genetic event. Usually that's how we kind of define cancer, as a genetic event, and triggers growth of these cells. But essentially, like I said, we can find neuroendocrine cancers in the lung, in the thymus gland, in the pancreas, in the bowel. So if you think of an organ, neuroendocrine cancers can happen there. Now, obviously, there's frequency differences in terms of how often we see neuroendocrine cancers for example, the lung would be the most common. As you know, like small cell, we have something called small cell carcinoma of the lung. That's considered a neuroendocrine cancer. And then next most common would be the bowel, small bowel. So that's kind of an overview of kind of what we describe as in terms of the origins of a neuroendocrine cancer.
Yeah. Are there consistent themes between neuroendocrine tumors across those different organs?
Yeah, the themes are that when you do a biopsy and you're suspicious that there may be cancer, and you look at the cells underneath the microscope, they have very familiar features. They have these, neuroendocrine type of, what we call like secretory granules, where essentially you can imagine the hormones sitting inside the cell, getting ready to be secreted. And then we stain them. The pathologist can look at it, the cells under the microscope, and they do something called a stain, which is essentially a marker where they could determine what the cell of origin is. And so there's a certain few markers that they can look that are consistent across the board, so that they can say, hey, this is consistent with neuroendocrine origin.
And do you ever run across neuroendocrine tumors that you are not sure which organ they were derived from?
Yeah, that's a good question. So that does happen. They describe neuroendocrine cancer or neuroendocrine tumor of unknown origin about 10% of the time that occurs. It occurs less, and we can talk more about that. But those same stains, those markers that I was talking about, that the pathologist paints the slide with, they have certain ones that can help in determining where the cancer started. For example, I won't speak in too many, abbreviations here, but CDX2, for example, that's one of the markers. And they could determine, hey, that's gastrointestinal origin. Or there's another one called TTF1, and that determines lung origin, or helps determine lung origin. So it's really important to work with the pathologist, because sometimes these stains aren't done like reflexively. There's a few that are done consistently all the time, but there's a few that you may need to ask for. Now, we talked about, you had mentioned maybe we don't know where it came from. Well, in the era of improved diagnostic imaging, so our CT scans, which more aptly I would say PET scans, we have special PET scans, which are essentially scans that will light up areas where the neuroendocrine cancer is. And so you're saying, well, maybe I don't know where it started. Well, sure enough, on that PET scan, I wish I could pull up some examples. It'll light up right in the terminal ileum, right where the small bowel meets the large bowel, right? And then you say, there's where it started.
Mm-hmm. So we like to, in between any discussion point, just make sure we define terms. So we'll stop and do that from time to time.
No, I like that.
So for anybody who isn't totally familiar, the difference between a CT scan and a PET scan. Do you want to take that, or do you want me to do that one?
Sure. I'm happy to. So a CT scan, essentially X-rays, fancy X-rays that give us pictures into the body. Usually we look at them in cross sections through the body, and they allow us to pretty much see what's going on inside the body. And with a CT scan, we can do something called contrast, where we inject a certain material, usually iodinated. We call it iodinated contrast. And what that can do is, when we're looking at the pictures on the screen with the radiologist or ourselves, the contrast will highlight blood vessels or allow us to see the inner workings of the body better. So a PET scan essentially uses a certain substance that, again, is injected into the vein that will seek out whatever area of interest you're looking at. So when we talk about PET scan, or in the general medical community, we're usually talking about a glucose PET scan. So essentially, you are injected with radioactive glucose, and wherever the body is metabolizing the glucose most readily, the cells that are using the glucose most quickly will, quote, light up. So you'll see those as bright areas. Now, we use the same technology through that glucose PET scan for neuroendocrine tumors. So we have a different substance that attaches to the cell, specifically neuroendocrine cells, and will highlight those areas, meaning they will be bright as compared to the rest of the CT scan or the PET scan that will be normal. And so we combine the CT, which gives you the pictures, with the PET, which is the radioactive material. And then we can see on the screen, essentially pictures that show us bright or not bright.
Yeah. No, that's a awesome explanation. Thank you. So I wanted to ask that question primarily because I think this is a bit unique to the neuroendocrine tumor space. Not totally now. Right. Maybe we can share with the audience that there are PET scans being developed for other tumor types. For instance, in prostate cancer, there's a marker on the surface of prostate cancer cells that you can use for a similar PET approach to try to identify very, very, very small amounts of cancer. One of the challenges with these types of imaging approaches can be that you can sometimes see false positives. You can sometimes see other areas of the body that can appear to have tumor present, meaning that could be not just a false positive overall, but could be a bit misleading. And so it's really important that as we think about these types of approaches, we understand how sensitive that is to pick up anything, and how specific it is to the tumor type. So can you talk about that for neuroendocrine imaging? Because I think that's a pretty key point to how you think about these tumors versus a lot of others.
Yeah, no, absolutely. So as you're alluding to, when we see something, quote, light up, we'll use that term as positive. When you see something light up, it doesn't necessarily mean cancer, right? Whether you're talking about the glucose PET scan or the neuroendocrine PET scan. And so it's a lot of taking into consideration the context of what you're seeing. So for example, the pituitary gland on the special neuroendocrine PET scan, quote, lights up. Well, there's normal expression of this receptor in our body in certain areas. So the parotid glands, some area in the pancreas, right? And so we have to determine, is it normal uptake or lighting up, or is it abnormal? And so with the modern day PET scan, so we used to have a PET scan called an Octria scan. And I would say, please don't have your doctor order that. It has a sensitivity of about 70%. So it's going to miss a lot of potential disease because the technology.
Let me pause for 1 second. Sensitivity means that when something is really there, it will find it, right? So 7 out of 10 times, it will actually show something to be there when it is there. Okay. And now the other side of that coin is specificity, which I'm sure
Specificity is when something is shown and it lights up and it's actually not cancer, right? So the specificity was closer to 90% for the Octria scan. Now, with the newer generation scans that have better technology, the sensitivity is now greater than 90%, meaning greater than 9 out of 10 times. If there is cancer, it will detect it, right? Now, as you alluded to also, there is a detection limit, right? So the scan can usually, we've historically said the tumor has to be at least about 1 centimeter. It's a little bit, the detection limit is a little bit better on these newer neuroendocrine ones. That traditional teaching was for the glucose PET scan, where something had to be 1 centimeter for the scan to reliably pick it up. So, it has to be big enough, or it has to be detectable to be able to be seen. But when it is detected, again, the specificity is also over 90%. So you have a test that has, or you have a scan that has a sensitivity, meaning it will pick it up over 90% of the time. And when it does pick it up, it's cancer over 90% of the time. So that's pretty good for a test. So
a concept we've tried to educate viewers on is this idea that if you can image a cell with a marker on that cell, then sometimes you can use that as a treatment modality. Is that the case in neuroendocrine tumors? So because you can find it with a special tool, maybe you can also direct therapy to it with a special tool.
Yeah, that's so that's a good kind of segue into a concept that we call theranostics. So let's break down the word. So we got thera, which means therapy, and then gnostics, which is diagnostics, meaning diagnose. So we found a way, the researchers, mostly in the Netherlands, found a way to identify a marker on the neuroendocrine cell, right? That was very specific for neuroendocrine cells. And we call that somatostatin receptor. Okay. So that's what we abbreviate SSTR. So you can imagine the cell, and then you imagine a little flag on the cell that is the somatostatin receptor. So with that flag, we can identify those cells. And as you alluded to, we found a way to attach to the flag, right? And we can both diagnose, as we were talking about with the PET scan, but what we've also developed is a way to deliver therapy to the cell. And usually that's in the form of radiation. So you would imagine almost like a Trojan horse. So you have the horse that finds the flag, and then once it does, the cell says, "Oh yeah, you're good. Come on in." And then once the horse gets inside the cell, radiation is released inside the cancer cell. So the theranostics is not necessarily unique to neuroendocrine cancers, but I think neuroendocrine cancers have definitely helped usher in this era of what we call theranostics.
Yeah, so this is a great place to pause to maybe just recap a little bit of what we've heard so far. So neuroendocrine tumors are derived from a certain subtype of cell. And that subtype of cell is actually a type of cell that can sort of receive information about things that are going on in the rest of the body, and then generally create hormones that are going to trigger some next effect. So in general, these tumors all have this one feature in common, that they're receiving information and then releasing a signal downstream to the cells around it or in the rest of the body.
Yeah,
so when we say neuro, we're kind of talking about the relationship between sort of an input and an output, and being the endocrine. And so somatostatin is a receptor, is a signal that each of these cells, or most of these cells, are going to have, that it's going to typically be receiving information. And then which information it puts out might be different depending on the subtype of cell. Is that all fair?
Yep.
So you've taken advantage of something that is almost always consistent across this very dissimilar group of cells that might come from different parts of the body to target it and maybe even treat it, right?
Yeah, that's really well put. I like that.
So tell me, what is the upside or downside of using a radiotherapy then? So it's a radioactive molecule attached to something that'll bind to the somatosense. What are the good things about that? Are there any risks? How does that work out?
Yeah, so the good thing is that you can, what we call, use a targeted therapy. So anytime we talk about targeted therapy, so we're targeting something that is specific about the cancer cell, you hope, this isn't always the case, you hope there's less side effects. And so sure enough, with this therapy, as compared to many other therapies that we have available for neuroendocrine cancers, has a lower side effect profile than most. So we use, and I don't want to get too technical, it uses something called beta radiation, which does not travel a far distance. So when the radiation is released in the cell, there's not a lot of collateral damage to the surrounding structures because the radiation doesn't travel very far. Okay. Most of the, if you look at the clinical trials, most of the side effects are fatigue, as with any, cancer directed therapy, or any therapy in general can have fatigue as the body is kind of processing the treatment, and kind of working through that. Joint pain, I've seen some patients get some hair thinning, is something. The other thing that's really important specific to this treatment is the bone marrow. So the bone marrow is the factory that produces all of our blood cells, our red blood cells, our white blood cells, our platelets, which have different functions, whether it be providing oxygen to tissues, white blood cells fighting infection, platelets helping our blood clot. And so there are somatostatin receptors in the bone marrow. And so you would imagine if this therapy attaches to bone marrow cells, it can suppress the body's ability to naturally make these cells. And because some radiation does affect the bone marrow, there is, depending on the literature, but a 2 to 3% risk of developing a leukemia. And so that is one of the specific concerns with this therapy that I highlight for every patient when we discuss this therapy, because the fatigue is self-limiting. It'll go away. The joint pain will go away. The hair thinning, the hair will come back. So nausea, people can have some transient, nausea or diarrhea. That'll all go away, but the leukemia is not going to go away so easily or at all. So we very much make it a point to discuss that as a potential side effect. The treatment, just real briefly, the one that we have that's commercially available, approved by the FDA, that we prescribe, is given once every 2 months, the therapy, for 4 doses. And we could talk a little bit about how that looks, when a patient comes in for that therapy, how long that they expect to be there and whatnot, depending on, what we want to focus on with our discussion.
Yeah, I wanted to ask, so in that scenario where you're using one of those therapies, obviously, I would imagine quite different depending on which tumor the patient has, right? So just a reminder, right? We started talking about neuroendocrine tumors being a big bucket of a lot of different tumors, depending on sort of where that tumor might, or where that neuroendocrine cell might have started. Are there scenarios where somebody can have widely spread disease that this type of therapy can result in a cure? Or is that, so for most solid tumors, we talk about that metastatic cancer is rarely curable for solid tumors. Is that the case in neuroendocrine tumors?
Yeah. So the key to determining whether this therapy will be effective is part of that coupling of the theranostics that we discussed. So when we do that PET scan, that I'm glad we built kind of a discussion around that for understanding, and we see whatever areas, quote, light up, right? We imagine that when we give the special therapy, which I'll now refer to as PRRT, which stands for peptide receptor radionuclide therapy. So when we give that targeted radiation, right, we imagine that it's going to go wherever we see the cancer, quote, light up, okay? It is not, unfortunately, a curative therapy, but it is a very effective therapy that can work on the order of years. Typically for slower growing cancers, which most neuroendocrine cancers tend to be slower growing, right? Patients have much better prognoses. Even in the stage 4 setting, I talk to my patients about the fact that for stage 4 cancer in neuroendocrine, for a low, what we call low grade, or what we call grade 1 or grade 2, and they're graded out of 1, 2, and 3. So for a low grade neuroendocrine tumor, patients can live, over a decade or longer. And so I discuss it as you mentioned, I think, or maybe Erica did, as chronic, as living with a chronic disease, right? So the response rates with the PRRT are not high for a small bowel neuroendocrine tumor, which is the most common that we would see, about 20%, in terms of response. But disease stability is a victory, right? So if a patient comes in and we say, hey, everything looks stable, there's been no growth, the therapy worked, right? Because it was growing and now it's not. So to answer your question, it is a stabilizing therapy that helps to continue the trend of this being a chronic disease. And the therapies that we build on try to continue that trend of, hey, you can live with this and live well, and try to offer therapies that have the least chance for, impacting that quality of life.
Yeah, there have been a number of, I should maybe go back about 10 years or so ago. I think most of our audience is probably familiar that there were some drugs approved that use some signals on the immune cells to try to get those immune cells to recognize and eliminate cancers. One of the interesting things about radionuclides, like we're talking about here, is that in preclinical models, they are exceptional at driving immune recognition of cancer cells. And so 6, 7, 8 years ago, there was a big effort on combining radiation-based therapeutics with immune-based therapeutics. How is that going in neuroendocrine tumors, since you already have such a highly specific way of getting radiation to the cancer cells? How is that combination working?
Yeah, so that's interesting. So actually, the first time you and I met was at an NRG meeting, and one of the big focus of discussion at that meeting was exactly this topic, and you spoke on it actually, with the highly kind of sought after abscopal effect, which we can talk a little bit about. But in any case, we historically have not seen very good responses with immunotherapy in neuroendocrine cancers. When we've looked at the drugs that you alluded to, which kind of unleash the immune system, which are FDA approved for many different cancers and are quite effective in many different cancers, we have not seen really any responses for the low-grade neuroendocrine. There is ongoing working groups within the NCI and otherwise to develop clinical trials. There's one in development right now combining immunotherapy with PRRT. So we will see if that's going to be a possible treatment modality in terms of improving upon what we already have. We also were looking at ways that we can target, as we had mentioned, that somatostatin receptor with something that you are expert in, with something called CAR T, where we essentially, you would explain it better than me, but we turn the immune system against the cancer, essentially. And those studies are still kind of in development. So I guess to answer your question, we don't necessarily have a treatment option at the moment where we can combine the PRRT with the immunotherapy or the therapies that we talked about to unleash the immune system. Excuse me. So stay tuned, I would say. There's a lot of what we call basic science papers where, scientists study how this looks in a lab or how this looks when you treat a mouse. And those look promising, but how that translates into the complexity of a human we always joke around. We've cured a lot of mice, and I wish we can translate those more.
Yeah. Maybe I'll share that this type of work was something that I was definitely a part of in my academic career. And I think it's an important thing to highlight that sometimes there is something that seems really obvious. It seems like it should work. And just for whatever reason, we cannot figure out why it does not work as well as we thought it would. Unfortunately, most of us that have worked in the world of translational medicine know that is much more common than the other way, where we think something's a great idea, it looks great in a mouse model, and it turns into something great in the human. That's actually, maybe 1 in 10, something like that. It's and even the 1 in 10 is rarely going to be as good as even what we're talking about. Like the therapies for neuroendocrine tumors or even checkpoint inhibitors in, say, lung cancer or melanoma or other cancers where we've seen great success. And it can be frustrating, I think, for patients because they say, I've heard my neighbor, had a head and neck cancer, got immunotherapy, and now is essentially cured. What's the difference? Why doesn't this work in neuroendocrine tumors? And I did want to maybe branch off into prognostic features and how, what do you look at in a neuroendocrine tumor where you say, I'm really worried about this person's cancer and less worried, for instance, about this other person's neuroendocrine tumor? Are there things you look at, in the patient's pathology sample or something else that tells you when to be worried and when, something might be a slower progressing cancer from the beginning?
Yeah. So this is good. It'll also be a nice segue into where immune therapy has been seen to work in neuroendocrine cancers. Because when we speak of neuroendocrine cancers or neuroendocrine, sometimes we'll say neuroendocrine neoplasms, which just is a fancy word for cancer, they occur along a spectrum, right? And so on this end of the spectrum is low grade, meaning slow growing, right? May change a few millimeters over the course of a few years. And then on the other end of the spectrum, we have a disease that's, rapidly growing and is life-threatening in the immediate future to the patient who may be dealing with it. So how do we determine that? Well, one, we talked a little bit about this before, is looking at the cells underneath the microscope. How do they look? And the pathologist is, again, crucial in making this determination. And I would stress that if you are diagnosed with a neuroendocrine cancer, to have a second opinion at a institution or a place that sees this cancer a lot. Because I often see that where it's determined to be something at one place, patients come to me and we review the pathology at Mayo, and it is something altogether different. And so when the pathologist looks at it under the microscope, they will say that it looks well differentiated, which means that it occurs in like little nests of cells. We talked a little bit about that, but the cells look like there's an order to them, right? And then that's on the end of the spectrum, the slow growing. And on this end of the spectrum, where we talked about really fast growing, the cells are just haphazard. They're growing, they're bizarre shaped, they don't have any order to them. And so that's important for us to know, because the nomenclature, the way that we describe these tumors, is really important to determining prognosis, treatment, everything. Everything hinges on the way that the cancer is described. So when we say well differentiated, or it looks neat and well organized under the microscope, that's a neuroendocrine tumor or a NET. On the other end of the spectrum, when it looks very haphazard and the cells are dividing rapidly, we call that a neuroendocrine carcinoma. So back in the day, maybe in the 90s, early 2000s, you could just throw around terms and there wasn't much weight behind it in terms of what did that really mean. Everybody would say neuroendocrine carcinoma, neuroendocrine tumor, but it's important in how these are named. So the pathologist looks under the microscope. They have another stain, or we talked about a marker that they put on the slide that can tell them how fast are the cells dividing under the microscope, right? So you take together what it looks like, how fast the cells are dividing under the microscope, and then you could determine and get a sense of how is this disease behaving, and then that portends prognosis, determines prognosis, and treatment. So it all starts there underneath the microscope. Now, just real quickly, the immunotherapy, when we've seen it work, it's been more in the aggressive neuroendocrine cancers, so neuroendocrine carcinoma. We published a series on that. We saw less exciting results than has been published otherwise, but there are a certain subset of neuroendocrine carcinoma, the aggressive ones, that will respond to the immunotherapy and will respond very well. I started a research project to try and help determine that, what would predict for patients who are going to benefit or are not going to benefit.
And in addition to that, are you also looking at markers of gene expression or genetic abnormalities in neuroendocrine tumors?
Yeah. So for genetic testing, it's really, really dichotomized as well in terms of for a well-differentiated neuroendocrine tumor, which we've now defined, and particularly for small bowel, which is the most common in the gastrointestinal tract, it is a very bland tumor in terms of genetic aberrations, abnormalities. So with the genetic testing that we have available to us in 2023, we don't find any markers on there that help us determine, hey, we can use this targeted therapy or we can use that targeted therapy. So essentially, it's not helpful, right? And it may be that we're looking at the wrong genes. It may be that we're just barking up the wrong tree. For pancreatic neuroendocrine tumors, I typically advocate for doing the genetic testing because there is more markers there's more genetic abnormalities that we can identify in pancreatic neuroendocrine, particularly something called MEN or MEN1 gene. And that can be important in determining could the patient inherited a gene that led to this from their mom or dad. Now, we went from over here on the spectrum to over here again. So we're now in the poorly differentiated or the neuroendocrine carcinoma. That is a place where I have found targetable mutations. So meaning there's a genetic abnormality that we can use a medication against. There's also on the genetic testing, and I know that One Cancer Place is kind of doing an emphasis in training folks on how to interpret these genetic tests we kind of vaguely refer to. There's markers on these tests that can suggest response to immunotherapy. So it's really important to know that. So again, that helps us determine, is that the group of patients is that the particular patient that's going to respond to immunotherapy? So it's not a panacea in terms of genetic testing for everybody with neuroendocrine neoplasms or neuroendocrine cancers. But I think you have to at least have the discussion of why or why not with your doc and say, hey, should we do it? And they will explain, hopefully, that, hey, I don't think it's going to be helpful here, or hey, yeah, that's a good idea. Let's do that. So I think it's worth a discussion no matter what.
And do you know Mark Lewis?
Yes.
Yeah. So just for the audience to relate back, one of our most recent shows actually was with Mark Lewis, and he talked about his familial multiple endocrine neoplasia, which is that MEN that you were just referring to. So I want to maybe highlight for the audience these kind of two concepts, right? There are genetic abnormalities that increase your predisposition to having a cancer. And those genetic abnormalities are ones that we would consider what's called germline, meaning that is everywhere in your body. And in certain cell types, that increases the chance of that cell type turning into a cancer. And so in these MEN, inherited traits, the abnormality that is found tends to increase the risk of having endocrine neoplasias or neoplasia or cancers in these types of cells. There are also oftentimes in certain cancers, there are consistent mutations that happen that are specific to the cancer. And then sometimes those can be diagnostic, sometimes they can be prognostic, and sometimes they can be predictive of a therapeutic effect. And the reason they can be predictive is that you can use a medicine to take advantage of what that mutation is making happen in those cells. So I just want to bring those concepts back together because I know they're pretty confusing if you're not just living in this world of like, why do we test for genetic mutations across like multiple generations of people? That's sort of these inherited things. And then why do we use genetic tests at all in various cancers? And we use them. Sometimes they tell us whether we should be really, really worried about somebody, but they also can tell us sometimes that we can use a certain therapy. And so I do want to relate this back to something we were talking about before, which is immunotherapeutics. We talked earlier about this concept that you might be able to sort of help the immune system along the way by using certain therapies like radiation. But you also mentioned this concept of using cellular therapies or CAR T cells. Mm-hmm. And maybe just again for the audience to quickly say that we can sometimes reprogram the immune system to go after a particular target. And so one thought people might have is, why don't you do that for the somatostatin receptor? And I think Dr. Starr was sort of referring to there might be some early work on whether that is possible. And I don't know how that'll play out, but I just want to point out that just because you have a good target for a radiation therapy doesn't mean it's a great target for T cells. It could be. It also can be dangerous because those targets might be expressed on normal tissues. So last point on this is that if something is a mutation that is super specific to the cancer, those can also be great targets for other therapies or immunotherapeutics. And Dr. Starr was just talking about that there are cases in neuroendocrine tumors where one of those could be used for, in this case, we're talking about a small molecule. Is that right? For a mutation?
For mutations. So unfortunately for neuroendocrine cancers in general, we do have what we call small molecule drugs, which are pills. We typically refer to those as like chemo pills. But they are not quite targeted per se. We give them what I would say non-judiciously, meaning they got approved by the FDA to be given in patients regardless of whether they have a mutation or not. We know where they work in the cell, but patients don't have a certain mutation to be the only ones to benefit per se. Unfortunately, we don't have.
When you were referring to a specific mutation that can be observed, for instance, in pancreatic neuroendocrine tumors, was what therapeutic is related to those?
Unfortunately, none. So as you talked about, the mutations that we find may be prognostic. There's the genes. There's a couple genes. There's one called ATRX and one called DAXX, and those are more prognostic. The MEN1 mutation is not necessarily targetable, but it's important because once you find it, it's important to determine, did the patient inherit a gene, as you alluded to, that the mutation, or was it acquired, meaning it happened in life and something went awry. But unfortunately, we do not have a targeted drug against a certain mutation in pancreatic neuroendocrine.
Okay. Yeah, maybe we should have said this earlier, because maybe it would have been a hook for people, but maybe the most famous person with pancreatic neuroendocrine cancer was Steve Jobs, right?
Yeah.
And I think that I remember, because I certainly am no neuroendocrine tumor expert like you are, but I did have a few patients that came into my clinic for phase 1 trials. And I remember people saying, like, well, I mean, if Steve Jobs couldn't, be cured or managed of this disease, how could anyone hope to be? Are there any big takeaway learnings from a case like his that, sometimes people ask about that you can share at all?
Yeah, I think it was a real missed opportunity, I think, for advocacy for pancreatic neuroendocrine tumors. Steve Jobs, could have been, huge in terms of improving notoriety of the disease, recognition of importance of new therapies. Essentially, Jobs was diagnosed with a localized pancreatic neuroendocrine tumor many years prior to it becoming problematic, and he was recommended for it to be removed. And he pursued alternative therapies. He felt that he could think it away, essentially, as it was described in his biography, which is by Walter Isaacson, which is incredible, one of my favorite books. But by the time he accepted that he had it, it had spread to the liver, and at that point, we really don't do liver transplant for that disease if it spreads to the liver. But he went to Tennessee and he said, I'm Steve Jobs, I think. And he got a liver transplant. And I think that the cautionary tale there is, as a corollary, you guys had Dr. Lewis on, who recognized, how important it was to have regular follow-up, and that surgery was going to be indicated at some point, which Dr. Lewis did undergo a surgery to remove these neuroendocrine tumors. So I think, with Steve Jobs, I think it's more of just recognizing, giving some pause to, what the disease can do if left unchecked. And the fact that, sometimes we have to kind of meld traditional medicine and alternative medicine. And I always say that, I'm very open to alternative medicine or integrative medicine, right? In terms of patients wanting to feel empowered, and what can I do to fight this cancer, or to treat this cancer, or to live with this cancer. But I think it has to be kind of arm in arm with our kind of proven therapies, because that's the problem with alternative therapies, is that a lot of times we just don't have the proof. And you and I are very data driven, right? It's kind of like, show us the data. But I also think we have to be open to living in a kind of the data free zone, and make it very specific to the patient. So maybe if that would have happened with Jobs, something different would have happened with his outcome. But if you read the biography, he was pretty stuck in his ways. Brilliant man, though. A shame.
Yeah. I think I wanted to highlight that early stage, low grade neuroendocrine tumors can be curable.
Very much.
Especially localized. And so it's a very important thing for people to hear. A lot of what we've talked about today, when we talk about systemic therapeutics, for most oncologists, our mind has already jumped to, this is late stage, or this is a bad, incurable situation. But I didn't want to leave people with the idea that there are not curable. In fact, a significant proportion of neuroendocrine tumors at diagnosis may be curable. Is that fair to say?
Very much so. Yes.
And do you ever use the therapies that we've discussed as an adjuvant or neoadjuvant type of setting. And I'll just remind everybody of what those terms mean. So neoadjuvant means using a therapy prior to surgery to increase the likelihood that the surgery is curative. And adjuvant means doing the same thing after the surgery to try to mop up whatever cancer cells might be left over.
Yeah. So we haven't moved to that kind of approach, mostly because the majority of the tumors that we're considering for resection are very low grade, slow growing. So a lot of times when a disease is slow growing, when you give a therapy, either it takes a very long time for that therapy to show shrinkage of the tumor, or there's never going to be any shrinkage because the cells aren't dividing fast enough for the therapy to allow, to cause shrinkage. One space that we is a trial is in progress is neoadjuvant PRRT. And essentially those are patients who already have disease that has spread, but it's trying to determine, could that help with improving the ability to resect the disease? And if the patient's being considered for surgery, because some patients, even with stage 4 neuroendocrine cancer, can have surgery, whether it's going to be curative or not is, more, I think, debatable, or at least, not as certain. But they're trying to determine if the PRRT could improve outcomes. Now, adjuvant, on the other side, we do have a national oncology, what we call cooperative group trial going on, which is kind of at the National Cancer Institute level. Dr. Heloisa Soares at University of Utah developed a protocol where we're giving chemotherapy after surgery for pancreatic neuroendocrine tumors. So we're trying to reduce the chance that the disease comes back. And so that was a big step forward, because for the longest time, we would always talk about it, but we're like, well, I wonder if chemo would prevent that. And now we actually have a trial to study that.
That's great. That's great. So it would, just again, for anybody, and maybe we could try to get that for the show notes, the clinicaltrials.gov number for that, since there may be people that tune in, but it's a really important study, and it does require, a significant number of patients to give of themselves to try to answer these types of questions. So, we do want to put in a plug for important clinical trials like that. It could end up saving a lot of people's lives over many, many years, depending on the outcome of a study like that.
Yeah.
We didn't talk about something really important. I just realized, because Erica put a question in the chat for me. What are the symptoms of neuroendocrine tumors? That's a broad bucket, but I guess maybe we can try to touch on it.
Yeah. We can go from top to bottom in terms of the body. So in the lung, neuroendocrine tumors can sometimes cause cough, wheezing, and shortness of breath. So those would be kind of the more common symptoms if somebody had a neuroendocrine tumor in the lung. In the pancreas, as we talked about a little bit, the pancreas has a bunch of cells in there that are responsible for producing hormone. So what we call the beta cells, for example, produce insulin. The alpha cells produce glucagon. So you would imagine if those cells go awry and start growing, then your body will start making too much insulin, for example. And then what would that look like? Well, your blood sugar would drop. You would develop sweating, confusion, nausea. So patients could have recurring issues with low blood sugar, and that could be an indicator that there is something amiss in the pancreas. Now, I will mention the great majority of pancreatic neuroendocrine tumors are non-functional, meaning they don't make hormone. So sometimes, and this is part of the issue with pancreas tumors in general, patients don't develop symptoms until the disease is maybe quite advanced, because it starts causing pain, and then it's quite sizable at that point and may have already spread. And that's also the issue with the other type of pancreas cancer. We just don't diagnose it early enough. Now, for small bowel, which is the most common neuroendocrine tumor that I see, some patients present with gastrointestinal bleeding, meaning they develop anemia. We talked about red blood cells. They can, that can also lead to fatigue or iron deficiency, where the iron levels get really low. Patients can also present with a bowel obstruction, meaning the tumor is obstructing the bowel's ability to move, contents, stool, through, and the patient develops abdominal distension, so the abdomen gets kind of full, nausea, vomiting. So that can also be a presenting symptom or signs or symptom. Now, the classical teaching in neuroendocrine cancers, when we're kind of learning this in the textbook so that we can take care of patients, is something called carcinoid syndrome. Carcinoid syndrome is very specific to neuroendocrine cancers. And we think about three particular symptoms. Flushing is the most common. So patients can get redness on their face and on their chest, and just feel flush and red, and it'll look red, it'll feel hot. No sweating with that, by the way. Diarrhea is the second most common symptom associated with carcinoid syndrome. And then the third is wheezing. So from the chest. So that's the classic teaching in terms of symptoms. Now, typically when we see carcinoid syndrome, it means that the disease is more advanced. It means that the disease has already spread outside of the area where it started. But those could be the first presenting symptoms. Now, I want to reiterate the fact that, when patients come to see me, I stress to them that for a low grade, small bowel neuroendocrine tumor, the prognosis is on the order of decade or longer, right? So I think some patients get really scared about having symptoms, right? And could kind of ignore them or wish them away. But I think it's just really important to advocate to, be evaluated, when you're having symptoms, because the news may not be as bad as you may think in terms of how that's going to affect your life.
Yeah. Maybe we can try to finish up on the conversation around where do you think the field is going? What do you think are going to be the next big impact, either clinical trials or new medicines or anything else you might be learning as you go that you'd love to hear that for the audience to know about?
Yeah. So I'll touch on a few things. Early detection, is always the holy grail, right? So if we can find it early and eradicate the cancer, that's always going to be our focus, right? And so there's a lot of these tests that are being developed, whether they be stool-based or blood-based, that's looking at trying to detect cancer at an early stage. I don't think that these tests are necessarily ready for widespread use until we kind of have some more information regarding their performance, because we talked about sensitivity and specificity, which was very appropriate as it relates to those tests, meaning how often do they actually find something? And when they do find, quote, something, is it a false positive or is it real? Because what can happen is you can start chasing your tail with test results, and that causes a lot of anxiety. But I think early detection is key, and it would be nice to have a test, and these are being developed, to be able to detect something early in the body that we can get rid of before it spreads. So that's the future in that regard. In the future, as it relates to, hey, the disease has presented itself, it's not amenable to surgery or removal. Some of the mainstay of therapy is called somatostatin analogs, which are essentially hormones. And the hormone, which is naturally produced by the bowel and the pancreas, is an inhibitory hormone. So when we give it as an injection, it will slow down the growth of the cancer cells. We give them once a month into the buttock area. They can be painful. And so we're trying to develop, there is in develop, and we have a clinical trial right now at Mayo and at many different sites, where it's a subcutaneous injection into the abdomen that's a much smaller needle, and patients can do the injection at home once every 2 weeks. So that's a huge convenience and maybe less painful, right? Because some patients dread those once a month injections because they hurt, and sometimes they leave little, what we call injection granulomas in the butt area, and patients can feel them. And that's really not, that's not pleasant.
Yeah.
And then there's also been development of an oral form of that therapy. So, that's on the horizon, hopefully. And then we talked about PRRT. So you alluded to kind of how can we combine PRRT with immunotherapy and help the immunotherapy or the PRRT both work better. So that I'm very interested in. And then there's new forms of PRRT. So you talked about, you kind of identified and conceptualized it well, like a little piece of radiation attached to whatever drug we're giving. Well, they're trying to change the type of radiation that's delivered. So we said, I had mentioned beta radiation, which is, a little bit esoteric, but they're trying to do alpha radiation, which is higher energy and travels even a shorter distance. So maybe even less side effects. So that clinical trial is open and ongoing. And then I think we need to do a lot better for neuroendocrine carcinoma. So remember that one we talked about on the spectrums, this one over here, the neuroendocrine carcinoma, the one that looks haphazard underneath the microscope. We need some improvements in therapy. We've been giving the same chemotherapy for 30 years now for that disease. And I think the immunotherapy, there may be something there. We just have to identify who really benefits and how more patients can benefit from the immunotherapy. And then new novel pathways to go after in this neuroendocrine carcinoma, because that's the one that can be very aggressive and life-threatening in the immediate future,
Yeah. Yeah, no, it's actually, it seems like the toolkit may be there, right? To start thinking about novel combinations and things that might really make a huge impact. But one of the things I remember I would always tell patients, and I think through this meeting we like to share, is that, good ideas require patience in being involved to see them through. Yeah. So it's important that patients educate themselves on these topics, that if they are willing to participate in a clinical trial, that can have a huge impact, not just for themselves potentially, but for lots of other people. And so I think, you touched on this earlier, but I would like to just emphasize that if you have a neuroendocrine tumor, you should almost definitely be seen by somebody who is an expert in neuroendocrine tumors, at least when you're starting your therapy and at any major decision point down the road from that. Now, if you can see somebody who is a true expert, like Dr. Starr, great, as your primary physician, but not everyone has that option. But if you can find a way, either with your own means or with a patient advocacy foundation that can provide travel assistance or whatever it might be, I cannot recommend more strongly that you go see somebody who knows these diseases extremely well for the key decision points. And second opinions, we've said it on this channel a million times, but second opinions should be considered the standard of care for almost all cancers, but certainly for more rare cancers and more difficult to manage cancers. Anything you want to add to that? I know I'm putting in a plug for you, but I want to make sure.
I appreciate it. Yeah. So, but yeah, when a disease is as nuanced as this, you really need someone who's doing it every day, right? And someone who can understand those nuances and put you at ease that you're on the right track, that whatever your oncologist has been recommending is the right treatment, because the mind and the body and the soul have to align, right? You have to believe in what you're getting is the proper treatment. Like they all have to line up, right? You have to be able to communicate with your oncologist. You have to be in terms of having an oncologist who's open-minded, who's willing to listen. Don't be afraid to ask questions. Don't be afraid to advocate for yourself. Because if you don't, sometimes, well, luckily you have places like One Cancer Place, but sometimes, you don't have advocates for you, or you don't know what questions to ask. I think the advocacy groups are a great point, because in neuroendocrine cancers, there is a lot of advocacy. the Neuroendocrine Cancer Awareness Network, Carcinoid Foundation .org, netresearchfoundation.org. I mean, these are organizations that exist to help you navigate this disease, including One Cancer Place, and hence we're having this discussion. But please, don't be afraid to advocate for yourself. Arm yourself with knowledge as a patient. And like I said, I like when my patients become experts in the disease because they understand what's going on, and then they can be confident in the direction they're moving because they have the knowledge. So those are just my parting words, but I think that the patient advocacy part is just huge.
I think that's a great way to end, because I think we talked about some scientific concepts. We talked about some real specifics of how some of these issues are managed. But the one thing that we try to make sure that people hear consistently across, many tumor types is the need for expertise, the need for a second set of eyes. And even if you can't remember all the details of the things we discussed today, you can remember that you can go find somebody who's an expert in your disease, no matter what that disease is. And in this case, we're talking about neuroendocrine tumors, but if you have a rare sarcoma, if you have a triple negative breast cancer, you should find somebody who knows that thing very, very well. They don't have to be the one that gives you your therapy every single day, right, but they really should be involved so that when there's a hard question that comes up, you're part of their care team. That expert is part of their care team. So, all right. Well, with that, I want to thank you, Dr. Starr, for the time, for all of your insights, and for dedicating your career to something that maybe is a bit more difficult because of the rarity of the cancer, and the fact that maybe there isn't quite as much funding around the research in these tumors as some others. I think it's always something we should applaud when somebody takes on a tough challenge. So thanks so much.
Thank you. I hope we got some CAR Ts that we can use against it. So that's my challenge for you.
Yeah.
So might I jump in and thank you both? I particularly want to thank you guys for the vocabulary lesson. I mean, that was really terrific, Dr. Chris, that you stopped and helped define some of these words. Again, in this session, I continue to learn. And to me, that's the path to survival. So thank you so much for being such great teachers, both of you. Thank you for the time and the pleasure.
Pleasure. Thanks, Chris and Erica.
Yeah, thanks. That was great.
Talk to you both soon.
Stay well.
All right. Bye, Erica. Thanks.
Bye.